Good evening, friends. Welcome to my YouTube channel, The Med Student. It's actually not my YouTube channel, it's our YouTube channel. So, this is a place where we will come discuss, we will learn, and we will improve ourselves and we will get better doctors day by day. So, coming to the point, so we'll be today discussing about pericardium and its diseases, pericardium and associated pathologies. So, what is called pericardium? What is called pericardium? Pericardium is nothing but the outermost layering or outermost covering of the heart. So, which is formed by the fibrous parietal pericardium, which is formed by collagen, and the visceral pericardium, which secretes the pericardial fluid, which is physiologically about 20 to 50 ml in quantity at a pressure of -2 to -5 centimeters of water. Okay, so this is a brief about pericardium. Coming to pathologies of pericardium. What are the pathologies that can be involved in pericardium? So acute pericarditis, which on the basis of chronology can be classified into acute pericarditis, subacute pericarditis, chronic pericarditis. Acute pericarditis is 4 to 6 weeks, subacute is 6 to 3 months, and chronic is greater than 3 months. Okay, so that is pericarditis, followed by pericardial effusion, followed by cardiac tamponade, then constructive pericarditis. So these are the main important pathologies of pericardium, which are mighty important. So we'll come to pericarditis. What is called pericarditis? Pericarditis is nothing but inflammation of the pericardium. Inflammation of the pericardium. So it can be divided into acute, subacute, and chronic based on the chronicity as we discussed. So what is called acute pericarditis? What is called acute pericarditis? Acute pericarditis is nothing but the acute inflammation, the sudden inflammation of the pericardium, which can be caused due to what are the etiologies. The most common etiology is idiopathic. So it's very funny actually. But reasons, idiopathic it's idiopathic, but it's actually presumably viral. So we can't go and investigate all these viral pericarditis. So we call it as idiopathic pericarditis. But it's mostly presumed to be a viral cause. Okay. So second is infective etiology. Infective etiology, which can be either bacterial, fungal, viral, or viral pericarditis. Out of viral, the most common is Coxsackie A pericarditis. Okay, Coxsackie A. So idiopathic infection, inflammation, autoimmune, which can be either secondary to SLE, rheumatoid arthritis, polyarthritis nodosa, etc. Okay, then inflammatory, infective, idiopathic, and what else? In infective only you can look on tubercular pericarditis, then constrictive pericarditis, constrictive pericarditis. Then finally, the mighty entrance important Purkinje's pericarditis. What are the most common drugs that can cause pericarditis? It can be isoniazid, hydralazine, isoniazid, hydralazine, and procainamide. Isoniazid, hydralazine, procainamide. Okay. So we have discussed what is pericardium. Pericardium is nothing but the outermost cover or layer of covering the heart, which is made up of the visceral pericardium that secretes pericardial fluid and covered by then the fibrous parietal pericardium that is made up of the collagen fibers. Inside it, we have the pericardial fluid, then which is approximately 20 to 50 ml in volume. Then we'll come to the discuss the pathologies. Okay, so now we are discussing acute pericarditis. So how will a patient present with acute pericarditis? We have discussed acute pericarditis. We are discussing acute pericarditis. We have covered etiology and now we'll go to clinical features. How will a a patient of acute pericarditis present to OP or casualty? So a patient will classically present with chest pain. So pericardial chest pain. Okay. So what kind of chest pain? A patient presenting with pleuritic chest pain where over the retrosternal area or precordial area, which can be radiating or non-radiating in nature, which is pleuritic chest pain. That is, it's aggravated on inspiration with or without beat to beat variability. With or without beat to beat variability. And what is the classical thing about acute pericarditis, the pain in acute pericarditis? This chest pain is relieved by sitting upright and leaning forward. Classical pruritic chest pain, which is relieved by sitting upright and leaning forward. Okay. So, any other clinical finding? What this chest pain is associated with pericardial rub. This chest pain is associated with pericardial rub. Pericardial. This chest pain is associated with pericardial rub. Okay. So, what is pericardial rub? What is the characteristic of pericardial? Pericardial rub is nothing but a scratchy pain. Sorry, scratchy sound, which is best heard with the patient sitting upright and leaning forward. It's actually a paradox. The patient is symptomatically best relieved in the position of sitting upright and leaning forward. That is the same position where, when that is the same position at which you can hear the pericardial rub clearly. So the patient is symptomatically relieved on sitting upright and leaning forward, but the pericardial rub is also best heard with the patient at sitting upright and leaning forward. Okay, this is quite a paradox, but this is what happens in a patient with acute pericarditis. Okay, so now we are coming to okay, pericardial rub. So, what is a classical diagnostic triad in case of acute pericarditis? In acute pericarditis patient, the patient will be having a pleuritic chest pain presenting with pericardial rub and ECG changes. So, as any patient, as any doctor, if a patient comes with chest pain, what will you take? ECG. So, coming to ECG changes in case of acute pericarditis. ECG changes in case of acute pericarditis. ECG changes. ECG changes in case of acute pericarditis. So, what are the ECGs? So, it should be there. Are we expecting any ECG changes in pericarditis? Like pericardium is not at all involved in the electrical conduction of the heart. It's not at all involved. But how can it cause any ECG changes? How can it cause? So basically, pericarditis is nothing but the inflammation of the pericardium. So inflammation of the pericardium. So there is inflammation of the pericardium. So whenever the pericardium get inflamed, there is adjacent epimyocardium. Epimyocardium is nothing but the myocardium which is adjacent to the visceral pericardium. So whenever this gets inflamed, this epimyocardium also gets inflamed. This inflammation of the epimyocardium that leads to epimyonecrosis and epimyocarditis and epimyonecrosis, which further leads to release of the cardiac markers into the blood from the myocardium, epimyocardium. So this is the reason, this epimyocarditis with epimyonecrosis is the reason why we are having ECG changes in case of pericarditis. Always keep that in mind. Pericardium itself is not at all involved in the electrical conduction of the heart. So, what are the ECG changes that you're expecting in pericarditis? It can be classified into uh, three stages: stage 1, stage 1, stage 2, stage 3. In stage 1, you will be having a P wave followed by PR segment depression followed by normal QRS wave with concave ST segment elevation and concave ST segment elevation. This is what you see stage 1 acute pericarditis. This is followed by in stage 2 after 2 to 5 days of acute pericarditis. The QR, the ST segment will be isoelectric followed by a normal QRS wave with normal ST segment, but T wave flattening will be there. This is followed by normal stage 3, normal P wave, followed by an isoelectric PR segment, followed by normal QRS, followed by T inversion. Okay. This is stage 3 of acute pericarditis, ECG changes in acute pericarditis. All this takes within a span of 2 weeks. After stage, after 4 to 5 days or 5 to 6 days, it will progress to stage 2. And after 2 to 3, 2 to 3 to 4 days from stage 2, it will result in stage 3. This all happens in a span of 2 to 3 weeks, can even take up to 4 weeks. It's a very slowly evolving process. Okay. So that is acute pericarditis, ECG changes. In stage 4, in some books, it's stage 4 is complete resolution with normal PV, normal PR segment, normal QR, and normal T. Okay. So this is ECG changes. So I mean, as both of uh, MI and pericarditis has ST segment elevation, how will you differentiate this thing from acute myocardial infarction? How will you differentiate pericarditis from acute myocardial infarction? In myocardial infarction, we'll be having concave ST segment elevation, unlike the convex ST segment elevation is myocardial infarction, unlike the concave ST segment elevation you are seeing in pericarditis. Then in my uh, in ST segment elevation in myocardial infarction can be localized, like one AV for lateral wall, two, three AV for inferior wall, like it can be localized. But pericarditis will have diffuse ST segment elevations with uh, without involving the AVR segment, okay, without involving lead AVR. So it will be present diffuse multiple leads. ST segment elevation will be there with peer segment depression that is classically seen in case of acute pericarditis. So can cardiac markers like top T, troponin T, troponin can it be used to differentiate this from acute myocarditis? This is a point of discussion, like not discussion exactly, but since a pericarditis itself will cause epimyocarditis and epimyonecrosis, there will be elevation of cardiac biomarkers in pericarditis as well. But the point is, yeah, but still it can be used to differentiate it between from myocardial infarction. How is, I mean, yeah, so you when the patient comes with chest pain, you will take the baseline drop I or drop T. Then after 2 hours, you will repeat drop by drop. If there is two times increase, I mean, if the initial second value is two times that of the first value, then definitely it points towards myocardial infarction. Okay. Or you can stick with if it's still maintaining the same, like initially it was increased, though there is not much increase within a span of 2 hours and it is elevated, then it is mostly suggestive of pericarditis. Okay. So acute pericarditis cardiac marker. Then other investigations are echocardiogram, CT, and MR. Echo will easily pick up pericarditis. CT and MRI are though not preferred. It can find pericarditis in areas which are not visible via echocardiography. Okay, so that is and it will give some clue about etiology as well. So this is in a pericarditis in a nutshell. So now coming to the management, acute pericarditis management. So it is bed rest, rest. The patient should be advised to rest, complete rest. Until when? Until the inflammation resolves. The remaining management is symptomatic management. So how will we manage the patient symptomatically? You will give pain relief by giving NSAIDs. So a patient presenting with acute pericarditis, the classical pleuritic chest pain, which is relieved on sitting upright and leaning forward, you will start the patient on NSAIDs. When is NSAIDs contraindicated in case of acute pericarditis? That is when the pericarditis secondary to post myocardial infarction. So in cases of post myocardial infarction, we are not preferring NSAIDs because it can increase the infarcted area. It can result in reinfarction. So that's why we are out. We should avoid NSAIDs in case of um, post myocardial infarction pericarditis. Okay. So you will give NSAIDs. In case of post-MI, you just increase the aspirin dose to 1 gram per day. That is 325 mg TDS. Okay. Always supplement it with a PPA injection, omeprazole 20 mg IV OD. So if you're giving omeprazole, always make sure that the patient is having it 30 minutes before breakfast. But if you're giving pantoprazole or omeprazole, actually it can be given at any time, before food, after food. It doesn't have any relationship with your food. So that thing you have to keep in mind. Then NSAIDs are other NSAIDs are you can give Brufen 200 mg, then or um, then what else we can give? Other NSAIDs. Oh, then the other mainstay of treatment is colchicine. So colchicine, what is the purpose of giving colchicine? Colchicine will increase the patient's sensitivity to NSAIDs, and it itself reduces neutrophilic infiltration, that thereby reduces the inflammation. But it also comes with side effects. What are the side effects of colchicine? Colchicine is a drug which reduces the cell turnover. So the gastrointestinal cells have rapid rapid regeneration. So when you're giving colchicine, this turnover in intestinal cells are affected. So this will result in the patient having loose stools. Okay. So the side effect is colchicine is granulocytosis, starting with loose stools, then it can even progress to a granulocytosis as well, because it will suppress cell division. Okay. Then colchicine. Then what if the patient, if you're giving NSAIDs and you're giving colchicine dose is 0.5 gram per time. You're giving colchicine, you're giving NSAIDs, still the patient is not resolving. You can start the patient on corticosteroids. You will be giving prednisone on 1 mg, 1 milligram per kg per day. Okay. 1 milligram per kg per day. Then you will slowly taper it over 2 to 3 weeks. You have to continue the treatment till the inflammation settles. Okay. So this is pericarditis in a nutshell. Thank you.